Thank you, Kari. Good evening. Thanks for being here. Okay, so we're going to start off with a little bit of audience interaction, okay? Got to get us off on the right foot, okay? So, show of hands. Who's heard about coronary artery disease and heart disease? Okay, great. And how many people have heard about risk factors for coronary artery disease? Okay. So let's hear them. What are they? Anybody?
Smoking.
Smoking. What else? Sorry? Blood pressure, hypertension. 3 more.
Sex.
Cholesterol. 3. Lower down. 2 other main ones. Calcium, no. How about, it's a good shot. What? Genetics, excellent. 1 left. My blood glucose is diabetes, that's right. You got them all, that's great, okay. How about signs and symptoms of a heart attack, right? We all familiar with those?
For men.
For anybody. Chest pain, shortness of breath, fatigue, right, all that stuff, okay? So now, what's the commonest place in the body that you're going to get plaque and blockages? Heart. Wrong. Your legs. Okay. So, the heart, you all said heart, you all got the good message. That's 4+ decades of good marketing from the cardiologists and the American Heart Association. Okay. The heart is one piece of the circulatory system. Okay. It's a bigger enterprise. It's the body's delivery system, transportation system for nutrients, oxygen, and waste elimination and offloading carbon dioxide. The heart, the pump, is one aspect, but you have the lungs, you have every tissue in your body, every organ has a blood supply and needs nutrients, right? And then you have a series of pipes. You have pipes that go away from the heart, the outbound pipes, and those are called arteries. So they're distributing the nutrients and the oxygen out to the periphery and out to all the organs. And then you have the return pipes that run in parallel, and those are called veins. Okay. So coronary artery disease, specifically, what is that? That is blockage of the coronary arteries, which are the pipes to the heart. If the pipes get narrowed or blocked and the muscle, the heart muscle, can't get fuel fast enough, there's a mismatch. And when that happens, the muscle cries out. You get chest pain. That's called angina. If the arteries get plugged up completely and you can't get any food or nutrients to the heart, that's called a heart attack because the muscle dies. Okay. But that same principle can affect any organ in the body. So here's some common ones that I'm sure you all have heard of. Carotid arteries and vertebral arteries that feed the brain can lead to a TIA or a mini stroke, which is angina of the brain, or a stroke itself if tissue dies. If it happens to the kidney arteries, you can get hypertension and renal failure. If it happens in your legs and your extremity arteries, you get a phenomenon called claudication, which we'll talk about later, but it's essentially angina in your legs, and leading up to tissue death or tissue loss, which is wounds that don't heal and gangrene. Mesenteric arteries, same thing, intestinal ischemia. We actually call it intestinal angina when you get abdominal pain when you eat and the blood supply can't keep up with it. Or on the venous side of things, the obstruction, you can get varicose veins, DVT or blood clots, or pulmonary embolism, which is clotting in the pulmonary arteries, so you don't get enough oxygen into your system. So again, the broader perspective, same concept, same principles. Vascular disease isn't just heart disease, it is a systemic disease. So you have to think about it systemically. And as a vascular surgeon, what do? We treat all the conditions of arteries and veins outside of the skull, except for the brain itself and the heart. Everything else is within the purview of a vascular surgeon. So we deal with a diverse set of abnormalities affecting every organ system. And there are fundamentally 2 things that we do. So like a plumber, You got a blocked pipe or an expanded or swelling pipe. Those are the conditions that we're really dealing with. So since I've been in the medical game, things have actually changed quite a bit in my discipline. When I started as a medical student, vascular surgeons had basically two tools in their toolkit, if you will. Medical therapy and then open surgical repair. And so that consisted of bypass, going around a blockage, endarterectomy, which is a limited removal of plaque in a defined area, or replacing sections of worn out artery with grafts, so like what we do for aneurysms. But over the last 25 years or so, this middle ground has evolved. The medical therapy is basically low risk, low yield, open surgery, higher risk, more invasive, better results. And then the endovascular solutions are now this middle ground of kind of intermediate to low risk, but being able to push the envelope of approaching open surgery. So it's keyhole surgery done through a needle, those kinds of techniques that have evolved that allow us to do more complicated things with better, quicker recovery times, less risk to the patient. And so that's one of my areas of interest, because expanding these techniques and the new technology that goes along with it has been fairly exciting. So if you think about, everybody's heard of angioplasty and stents these days, but they've only been around since the late 70s. The first angioplasty was performed in the heart in 1977. And what an angioplasty is basically it's a forced rupture or disruption of a tight area or a blockage in an artery. Because an artery is an elastic structure. When you feel a pulse, you're feeling the elasticity of the pulse as it propagates down. But when plaque forms, it stiffens that area and forms the obstruction. And in some cases, it becomes very calcified or it becomes circumferential. So in order to open that up, you're actually disrupting the elastic fibers in the artery because you're trying to overstretch it a bit and trying to essentially do a controlled tear or disruption of the plaque to separate it off the wall of the vessel. That's how angioplasty works. But cracking plaques and rupturing plaques and tearing arteries and tearing elastic tissue, what does that bring to mind? Wounds, scar, wound healing, right? And if these stiff areas kind of shift or get partially off the wall, you can get things like what we call dissections, and they can lead to clotting and what we call restenosis. So the scar tissue re-narrows that section. So as a vascular surgeon, I was told by my early mentors, you're kicking the can down the road. This is basically you're robbing Peter to pay Paul. We're going to treat your condition now, and what we're going to do is going to induce scar formation. And in time, we're trying to modulate or let that scar kind of go through its natural healing phase to thin out in the hopes that the downstream vessels don't get sick or poop out as this settles down. So that's the shell game that a vascular surgeon deals with. And that also applies to cardiac surgery and cardiologists who are doing the same sort of things in small arteries of the heart. That's why we have recurrences. That's why we do surveillance. We keep an eye on this stuff over time. So a stent, so what's a stent about? So when you take these complications of angioplasty, the stent is like a metal scaffolding to basically prop the artery open that you've kind of forcibly torn on the inside to kind of hold it open and try to reduce the chance of recoil and scar and tack up all those loose, broken areas. But again, that's only been since the mid-'80s. The first coronary stent for an acute heart attack was in '91, and the FDA approved stents for use in angioplasty complications in 1994. Then there was a play in '99 of putting drugs on the stent to try to reduce the scar formation. So that's the modern heart technology that you have now, is drug-coated stents. That's what that's about, but it's only been around for 25 years. For a vascular surgeon, this number 2, 1992, first aortic endograft, that turned our whole discipline upside down. An Argentinian vascular surgeon named Juan Perotti took actual graft material, Dacron, put stents on either side of it, rolled it into a tube, put it in the bloodstream, and fixed an aneurysm from inside the aneurysm itself. And that was a total game changer. I spent my career studying these things. That was the focus of my research because it was so revolutionary. And that's really flipped the whole paradigm in vascular surgery from, like when I started, 85% or more of what we did was open surgery, where now 85% of what we do is endovascular surgery. It's moved the needle that much. So medical therapy, what does that mean? Risk factor modification, blood thinners, antiplatelet agents and anticoagulants, and exercise. That's medical therapy for a vascular surgeon. Use it or lose it. And the risk factors that you're all familiar with, okay, basically think of them as 3 toxins, a kind of mechanical issue, and then a wild card, your genetics, pre-programmed cell death or abnormalities. The toxins have kind of the most risk associated with them. And what I tell patients is controlling your risk factor is reducing the rate of deterioration of your condition. It's a systemic problem. It's going to get worse over time. It's just how much gas are you putting on the fire? Smoking is a 10 times accelerant. That is why it is the #1 thing that we try to get people to stop doing, because you get worse a lot faster in a more uncontrolled way. Diabetes is number 2 because it's a 4 times accelerant. And then you can see the rest of the numbers there. So when it comes to vascular disease, the single most important modifiable risk factor is smoking. And then 90% of patients with vascular disease in their legs have smoked at some point in their life. Okay? Smoking attacks the medium-sized vessels. So like the femoral arteries in the thigh, the kidney arteries, the carotid arteries, that's usually smoking is where you start to see those effects. And it's dose dependent. Okay? Less dose, less risk, higher dose, higher risk. And then back to my earlier lead off, thinking that the heart was the commonest place to get vascular disease. Legs is number 1, heart is number 2, and your carotid arteries are number 3. Diabetes, again, risk of peripheral arterial disease is proportional to the severity and the duration of the diabetes. And it tends to affect smaller vessels. So usually in the leg, it's from the knee down or the foot. So small diameter vessels, small diameter coronary vessels, more of the peripheral branches tend to be where the diabetes attacks. So think about that. If you put smoking in tandem with diabetes and you're wiping out your medium vessels and your small vessels, that's why 1/3 of people who smoke who are diabetic end up with an amputation within 5 years. Okay? And most non-traumatic amputations are done in diabetics. Okay? Lipids, I think everybody knows these numbers pretty well off the top of their head. Basically, total cholesterol, HDL, bad cholesterol, and triglycerides you want to get down. Your HDL is the good cholesterol, you want to go up. And those are the kind of target numbers that we use. Controlling with diet and medication reduces heart attack and stroke rates or stroke risk, but you're not reversing the plaque, okay? In animal models, if I feed you a high cholesterol diet, you'll develop plaque. If I withhold that high cholesterol diet, those plaques will actually go away. Doesn't work that way in humans. There's an oxygenation step in the biology that once that molecule gets in the cell wall, oxygen molecule gets attached to it. It's a ball and chain. It won't go back through the door. It's stuck. The person who figures out how to deal with that will become the first trillionaire because everybody is going to want that medicine. And statins, like I said, doesn't make the plaque go away. It just reduces the rate at which the progression occurs. It reduces the rate of heart attack, death, stroke, and the rate of worsening of PAD. Interestingly, in most coronary artery disease patients, they're on a statin. But if you take coronary artery disease out of the equation and you're just dealing with peripheral vascular disease, only about half of people are on a statin. It's because PAD is under-recognized, under-treated, kind of generally speaking, which I thought was kind of interesting. Hypertension increases your risk, and family history is an accelerant for those categories there. So the big three we deal with as vascular surgeons are peripheral arterial disease, stroke, TIA, and aneurysm. So we'll touch on a little of those through the night here. So this is peripheral arterial disease. Y'all see the difference? One on the left, blocked iliac artery, which is, there we go, this. And that's a stent. Big flow, no flow. Okay. So how prevalent is this? Age 65 and over, 1 in 5 have it. And over age 50 diabetic, a third of them have it. Most patients are unrecognized. So only about a quarter of those with peripheral arterial disease are actually symptomatic and being treated. There are a lot of folks out there that are either symptomatic and not recognized as being symptomatic with vascular disease, or aren't recognized at all, or may not have symptoms. There is a little bit of a disconnect between patients who have blockages and the physiology and the symptoms that go along with it. And that's because longer section of vessels, you can develop collaterals over time that may pick up the slack in some form or fashion. And then again, higher risk. So think of it as a marker. PAD patients, if you find somebody with blockages in their legs, they likely have it in their heart, they likely have it in their carotid, and they're at high risk for strokes and heart attacks. Symptoms can be as subtle as like diminished hair growth or nail growth at the digits, up to claudication, which is kind of the first symptomatic level that we talk about. Claudication is pain in the muscle group when you're using the muscle group. So typically pain in the calf when you walk, or pain in your hip or buttock when you walk. That's claudication. And it's due to the mismatch between blood flow while it's in use, or the next level is sores or wounds that don't heal, or ulcers or gangrene. So these are kind of the stages it'll go through. And it is a spectrum. So you can be non-symptomatic and move into a claudication section, and then you can start get tissue loss or rest pain or gangrene. So there are opportunities to abort or divert or deal with these symptoms at many stages in the game. We see a lot of presentation with late stage disease coming in here, necrosis or gangrene. And what we really want to do is get you kind of in here, where you're really limited in your ability to walk. But this is kind of the differentiating level between kind of mild disease where the risk of losing a limb is low, and this is really tissue loss where the risk of losing a limb is quite high. So that's kind of the break point. So the goal when we work people up is to locate the lesion and define its functional significance. If we see 100% blockage and the patient is like, yeah, I can walk as far as I want and I'm good, okay. We monitor them, control your risk factors, monitor it, check the duplex and the blockages over time. But you have people who have blockages and they can walk, 10 feet without being severely symptomatic. They can't go to the grocery store, they have to stop 5 times or 10 times in Costco, all that kind of stuff. It's like it's a problem for their lifestyle. They can't do what they want to do. It's always a nuisance. So then we talk about fixing it. Simple things, physical exam, what we call an ankle brachial index, which is basically your blood pressure at your ankle compared to your blood pressure in your arms, and we come up with a number. And it gives us basically a percentage of your blood flow. So 90 and above is considered normal, 50 and below is considered severe, 50 to 75 is moderate, and 75 to 90 is mild. That's how it breaks down. So we use that as a scale. So patients who have seen me and had ABIs done, this is kind of how we gauge both where you're at, how you respond to treatment, and then after we intervene, how much improvement do you have? And then the duplex is basically our stethoscope. We can use ultrasound to define the lesions and their significance based on the Doppler effect, if you will. Again, the patients come in with exercise-related pain in various large muscles. And okay, here's a little pearl, if you will. The trick, it's one joint level below where the blockage is. It's a good medical student test question. If somebody hurts in the calf, you're looking for the blockage in the thigh. If they're hurting in their buttock area, it's up in their abdomen, in their aorta, their iliac. It's one joint level below is where they hurt. Okay. And it's usually goes away with a minute or two of rest. And then they have vascular risk factors too. So to differentiate that from spine conditions, a spinal stenosis or sciatica, people are symptomatic sitting in a chair or standing up, but actually walking can often make them feel better. So, you know, you come into my office and you give me a history, it's killing me when I stand, and you're not walking? No, well, that's your spine. But it's not your vascular system. So that's how another differentiating factor. Muscle cramping at night, get this a lot. It's not vascular because you're not moving, unless you have rest pain, which is different, but you're not going to cramp. Usually you're going to get numb or tingly. But we differentiate that, you know, there's no known vascular basis for muscle cramps at night. So getting back to, we have a patient who has the appropriate symptoms, they have a problem, what are we going to do with you? If they fail medical therapy or they want something done about it, then the interventional options are basically less invasive endovascular treatments or potentially more invasive surgical options. And again, that paradigm has shifted over time. In the past, we used to say, well, we'll do the really hard, high-risk patients, the high-risk patients with the bad COPD and multiple medical comorbidities with an endovascular fix because we don't want to put them to sleep, okay? Or the chip shots, like, oh, you got 2 centimeters of a blockage and everything else looks normal. Those are the ones that we tended to do with the endovascular treatment first. Nowadays, as the technology has gotten better, we're taking on more and more complex things with less invasive kinds of therapy. So it's switched over to basically endovascular first, and open surgery becomes the failure bailout. So if it's not possible, the lesion's been there so long you can't get through it all, or you've had numerous endovascular attempts, and then like on the 3rd time it's failed again, so then you switch gears and go to a bypass. Severe distal disease or challenging anatomy, those are kind of the things that go into the open bucket nowadays. So endovascular interventions include all these things. Angioplasty, like we talked about, where they have variations on the theme with either what they call cryoplasty or a freezing balloon to try to reduce the fracture magnitude, or actually cutting balloons that have razor blades on the ends that you actually score in a controlled fashion, the plaque. Stenting we talked about. Atherectomy is actually shaving down or trying to debulk the plaque itself. So there are things like what they call a rotablator, which is like a drill bit that, you know, basically polishes it down, the plaque down. Other areas where they actually shave sections of the plaque down. Another version is almost like a lithotripter for a kidney stone, where they have emitters on the balloon that actually fracture the plaque. And the last thing is a laser, which is, I kind of use it like a jackhammer, where you have a total blockage and you're able to get a pilot hole through that with the laser. And if you can develop a channel, you can put through a wire, and over the wire you can deliver balloons and other therapy to expand the channel or the blockage. So that's pretty much the approach. And this is what it looks like. So this is a simple angioplasty. You have the lesion here in the superficial femoral artery, and then you balloon it open and you get it open. But here's the other extreme, of a patient with tissue loss. This is the superficial femoral artery from their groin is here and their knee is here. So this artery is totally obstructed. You can actually see the calcium in the wall of the vessel. And with a laser, you're able to drill through this and deliver a wire through it, which you can kind of see the wire right there. So you can see I have a channel. It doesn't look great, but at least there's flow. And by the time you've sequentially ballooned it, and then these are called covered stents. They're Gore-Tex on the inside, stent on the outside. So this is actually an internal bypass that you've reconstructed and recycled this worn out tube here. And that's probably an hour and a half to 2 hours worth of work rather than 4 hours worth of work. This patient goes home the same day as opposed to staying in the hospital 3 to 5 if we were to do a bypass. So that's the difference. Okay, stroke and TIA, another of the big three that we deal with. So the circulation to the brain, I know this looks complicated, but there's basically 4 arteries you need to worry about. There is your carotid artery right here. It's got an extracranial portion that stays outside the skull, an intracranial portion right here. And there's basically 2 branches off the internal carotid. This branch right here, called the ophthalmic, that goes to your eye, and this one up here, which goes to your brain itself, okay? The back of the brain artery is called the vertebral artery. It comes up and it goes in the wing of the bony part of the spine and the neck, and then it comes together with its partner on the opposite side to form the basilar artery. This area here is called the circle of Willis. So why that ophthalmic is important is any debris or junk that embolizes off of a plaque goes up here. It's got a fork in the road. If it goes to the eye, you get an eye stroke, or a phenomenon called amaurosis. It's like a black shade coming down. Or it goes to your brain and you have a mini stroke or an actual stroke. So people who've had amaurosis, that basically is a stroke that went to your eye and saved it from going to your brain. If you look at the intracranial part of things here, that's this. Okay, so here is your 2 carotids, boom, boom. Here's the vertebrals and the basilar. These go to the back part of the brain, and then this is called the circle of Willis. So there's these arteries that connect them all together into a loop. So what I tell my patients is think of it like a chair. Got 4 legs and a platform. The circle of Willis is the platform you sit on, and the other 4 arteries are the platform of the chair. Why is that important? Backup, redundancy, you know. So you can actually knock out a complete vertebral and still perfuse the back of your brain. You can knock out a carotid and still perfuse your brain. You could knock out both carotids and still perfuse the back of your brain through this whole architecture. Where we get into challenges is this circle is only complete in about 60% of us. So there are patients who have like this connection may be broken, or this connection may be broken. So that's where people have issues with strokes and stroke dynamics. But the bottom line is there is a lot of redundancy in the system. Most strokes are what we call ischemic, lack of blood flow. There are hemorrhagic strokes, which is basically bleeding in the brain. But most ischemic strokes are atherosclerotic, blockages in the carotid arteries. And this is what we're talking about right here. And we're dealing with extracranial carotid artery. And the whole point here is stroke risk prevention. Carotid artery disease in the vascular surgeon is the only thing that we do prophylactically or preventatively. We take somebody with a condition at high risk for a stroke and try to prevent that stroke from happening. You know, if you've had your stroke, we can't take that damage back. So we do try to mitigate that going forward with procedures, but we want to try to avoid strokes at all costs. So symptoms, so this is your brain heart attack comparison here. So symptoms of a stroke: numbness and tingling, weakness on one side of your body. And it's usually on the side opposite of the brain that's being affected. The amaurosis piece, the eye stroke, is on the same side as the lesion because it's on the ipsilateral branch. And then inability to speak is basically you can think the words but have trouble expressing them. And that's usually particular to the left side of the brain. So it helps us identify where the lesions are. What's the difference between a mini stroke and a stroke? TIA is a mini stroke. It's based on duration. So it's usually 24 hours. So if you have symptoms that completely go away within 24 hours and you scan them and there's no actual infarct or spot on the brain scan, it's a TIA. If you have symptoms that go away within 24 hours but you have a spot on your brain scan, it is a stroke. They're seeing, dead tissue basically. So if you have dead tissue, it's a stroke by definition. And if you have a persistent neurologic deficit beyond 24 hours, that's a stroke. Even if they don't find the lesion on the scan, by definition, it's a stroke. So that's how we differentiate. And why that's important is because it dictates how and when we treat you. 2 pivotal studies done. This was kind of major studies that affected how we treat carotid arteries that was done in the mid-90s. One of them was called NASCET, the other one was called ACAS. NASCET was a prospective randomized trial of medical therapy versus surgical therapy, carotid endarterectomy for stroke risk reduction and prevention. And what NASCET showed was that there's a statistical advantage for treating symptomatic patients with a 70% blockage by cleaning it out surgically than leaving them on medical therapy. And the advantage is 21% to 4%. So you reduce your chance of having a future stroke the lowest by having a carotid endarterectomy in that circumstance. ACAS did the same sort of thing, prospective randomized, but they took non-symptomatic patients and they lowered the threshold from 70 to 60%, which seems kind of bizarre. It's like, why would I lower the bar for non-symptomatic patients? You'd think you'd raise the bar. But that's how the study was designed. And the bottom line is the absolute numbers are less in every category, but the same statistical benefit held up. So based on that, we say 70% blockage in your carotid with or without symptoms, it's best to have the carotid cleaned out with an endarterectomy to reduce your chance of having a stroke. And in some cases, 60%, even without symptoms, can be advisable. So that's a patient-to-patient, patient-to-physician kind of decision on what's right for them. The workup, basically physical exam. A bruit is the doctor puts a stethoscope on your neck and hears a whistle. He'll hear a whistling sound. That's called a bruit. That's a marker for a blockage. It deserves an ultrasound. A lot of them turn out to be the external carotid, which is the perfusion to the face, and that's what they're hearing. But you can pick up internal carotid blockages that way as well. So we check it out with an ultrasound. Neurologic deficits are obvious, or if you have vascular risk factors in any of those. So usually the workup is physical exam and a duplex and ultrasound, cheap and easy, get a good view, and based on that information will tell us what category you fall into. We do CAT scans and MRs to look at infarcts and bleeds, and we can look at more intracranial carotid artery lesions as well. But the workhorse is an ultrasound. So you got a blockage less than 50%, we check you once a year. If you're 70% or more, we talk to you about surgery. If you're 50 to 69, we check you every 6 months. If you have symptoms, then we can potentially fix that in the 50 to 60% range in certain circumstances. If you've got a 70% blockage and no symptoms, whenever's reasonable, whatever works for your schedule will work. If you're having a TIA, we try to get those people in the operating room within 24 hours. And if you're actually having a stroke, if you don't catch it in the first 6 hours, you actually have to wait for the brain to heal for a couple of weeks before you subject the patient to an endarterectomy. And then again, in some circumstances, we can lower that bar, and interventional therapy may be a possibility as well. So this is a carotid artery, and this is the internal that goes to the brain. This is the common. This is the patient's brain is this way. And this stuff here is the plaque inside the wall of the vessel. So we'd actually cut into this, scoop this out, or cleave it out of the wall of the artery and repair that. That's a carotid endarterectomy. Takes about an hour. Yeah, looks good till you have it. And this is a carotid stent. So this technology has evolved in the last 15 or so years. Basically a system to stent the carotid artery. Now, some of the nuances are, we talked about angioplasty risks of dissection, thrombosis, embolization, right? So if this junk breaks off, what happens? Up it goes. You got number one or door number two, right? Your eye or your brain. So what we do is we put in what's called a basket, cerebral protection device. And so you put a skinny wire through the lesion, unfold the basket, which is this, up in the skull in the intracranial part of the carotid. Then you can have your way with this vessel. You can balloon it, you can stent it. That's what this cage is. They put the stent in to cross this lesion, and at the end of the case, they save this person from having a stroke, because that is a stroke that didn't happen because of the cerebral protection device. Carotid stents we do in higher risk surgical patients. So there's a certain set of criteria that we use, because the risk of having a stroke with the stent is higher than the open surgery. It's about double. So it's been reported as high as 11%, but in a high-risk patient, it may be worth it. So we tend to do them in like people who've had neck radiation, redo surgeries, bad coronary artery disease in conjunction with carotid disease. There's a whole list of other high-risk categories, if you will. But stenting, it's kind of mainstream, if you will, but we tend to use it for higher risk people just because of the additional risk that goes with it. Now the risk is practically, it's double, so it's probably like closer to 4 or 5%, but it's not 2% or less.
And that's a basket that like it catches clots that would be coming up, is that what you're saying?
Yeah. So yeah, as this gets manipulated, this lesion, and junk breaks off as that plaque fractures, it showers, this trap is a filter. This is one design. There are actually 3 or 4 different kinds of designs, but it's meant to catch the debris. So it's sized to fit the artery. You don't want it too small because there'll be ways around it. And then you collapse it down and you snag it. It's like
Fishing.
yeah, fishing, if you will.
So you don't leave it in place, you take it out.
At the end of the case, you take it out. Yeah, it's a temporary thing. It's only there while you're manipulating the artery. So that's carotid stenting, okay? The last thing we're going to touch on are aneurysmal disease and that interesting revolution from the 90s. So it used to be, again, open repair, and now this is like the generation 1 of an endovascular repair, relining the artery from inside the artery. And the key here is you need what we call a seal zone. They're oversized and held in by friction, but you need a section of good artery above and good artery below so you can get a good watertight, blood-tight seal on either end so that this big balloon is no longer pressurized. The pressure goes through the new tube and this thing starts to deflate, okay? This is now like 3rd generation technology where this was actually one of my favorite devices, but it's being used less commonly now. Some NASA engineers developed a polymer seal, so this is like a low pressure gasket that gives you this friction seal here that seals this into place approximately, and then it's suspended by the hooks. But a different twist on the same theme.
Is this stuff done like microscopically or with robots or?
Nope. My hands, small incisions or needles.
And this is very small stuff.
Yeah, so this thing, these devices, so this here can go up to 34 millimeters in diameter, so 3.5 centimeters. We have versions that go in the thoracic aorta that can go up to almost 48 centimeters, so almost 5 centimeters that you can seal to. So they're basically packaged into what we call catheters, but tubes. They're like fishing poles that we put into the bloodstream over a rail or a wire, and we get them into position, and we can kind of open them up and position them and then deploy them. So that's how it's done.
They do that in drain lines and stuff like that, inside sleeving or an outside, you know. A lot of times they go into steel pipe, just got a crack in it and use
Yeah.
PVC or something.
Yep.
Must have come from this, huh?
Well, it's, yeah, we're plumbers. It's
That
a,
was a great surgeon.
we're all plumbers.
He wanted to make money on the pipeline, so he went into sleeving the
Yeah,
big stuff.
it's the same concept. The same concept. Okay. So we talked about the term aneurysm. What is it? It's an abnormal enlargement. And the definition is 1.5 times the normal size of the artery. So it will depend. You can have an aneurysm in any artery. So we're talking specifically about the aorta, the main pipe, but you can have it anywhere. Brain aneurysms, leg aneurysms, kidney aneurysms, any artery. And so again, we define it as 1.5 times the normal. And so what does that look like? So in the chest, you're at, basically 3.5 centimeters. In the abdomen, the aorta is 2 centimeters. In the iliac, which is those first leg branches that we saw in that earlier slide, that's typically a 1 centimeter vessel.
So what causes the weakness, do you think, it sort of expands?
It's genetic.
It's all genetic?
It's genetic.
It's not dietary?
No. So it's a genetic predisposition that basically collagen and elastin metabolism is disrupted, balancing kind of breakdown of those fibers compared to buildup, and you get a net weakening over time. We'll talk about risk factors for that as well, but it's a genetic issue. And they tend to run in families, and they tend to be associated with other aneurysms. There's an association between abdominal aneurysm and leg aneurysm. So if you find a leg aneurysm, you got to look for an abdominal aneurysm. So it's a genetic issue. Oh, am I out of time? Oh. Oh, there we go. So again, this gives you an idea. This is a thoracic aorta, so your heart lives here. So this is the ascending aorta, which would be this aneurysm. This is a descending thoracic aneurysm, which is this bulge. And this is an infrarenal abdominal aortic aneurysm, which is right here. And this is the commonest aneurysm. 13th leading cause of death, 2 million people in the US, and 200,000 diagnosed annually. And why do we care about it? Rupture. Just like a balloon, the bigger it gets, the greater chance it's going to blow, okay? And the risk of rupture is an exponential curve. It's not a linear curve. So that is most important. About 20% of people, they present with a rupture, and they never knew they had an aneurysm. So that's the whole point, is we're trying to avoid death from rupture in the silent killer. The survival rate, this is it right here. You need emergency surgery for a rupture, there's a 50% chance or more you're going to die from the procedure, or not from the procedure, but from your condition, and the procedure isn't going to be able to rescue you. Elective surgery, the mortality rate's 2 to 5%. This is huge. This is the whole justification for screening programs. Okay. Average growth can be up to 10%. So we say 4.5 millimeters a year is kind of expected. Anything above that is unstable and rapid growth, so that's a problem. It grows at a lower rate at smaller aneurysms, and rapid expansion is associated with age, smoking, stroke, high blood pressure, and heart disease. So those things make the rate of expansion and your risk higher, rate of expansion worse. This is kind of that exponential curve. If you show up in my office with a 7 centimeter aneurysm, basically there's a 75% annual risk of rupture. So, but it's 35% at 6, and we fix them at 5. This is 15%, and the difference between that elective mortality and the rupture risk is statistically significant. And in females who have slightly smaller aortas, we can drop that threshold number down to about 4.5. So if you're a small person with a small artery and you have a 5-centimeter aneurysm, it's like a guy coming in with a 6-centimeter aneurysm. It's all relative. A lot of these you can feel. So if you do a good physical exam, you can actually pick them up just by feeling them. You can't get a good estimate of size. You can tell there's a mass, it's a lump, it's pulsatile, but you know, you're not going to precisely define how big it is, but you know it's not normal. And then check for other artery aneurysms, and it's often picked up on unrelated studies. You know, you get your back looked up and they find the aneurysm. You get your chest CAT scan for your lung screening and they find the aneurysm. So that's how a lot of these things are picked up. Medicare screening, one-time benefit within the first 12 months of enrollment. If you smoke more than 5 packs of cigarettes or you have a family history, it's available. Follow-up, we usually follow them up. If they're more than 3 centimeters, it's an aneurysm. So if you're under 4, we check it once a year. If you're 4 to 5, twice a year. If you're more than 5, we fix it. And then we do CAT scans to plan out those endovascular fixes for measuring sizes and devices and things like that. Prevent rupture, prevent death. This is an aneurysm. All this is the hematoma from the rupture in the back. So that's what we're trying to avoid. So again, this is the Gen 1 we talked about, held in by friction, so we oversize them by about 20% when we put them in. And so this is an open repair. So this is the aneurysm here. These are the iliac arteries. Greater length of stay, usually about a week in the hospital, half of which is in the ICU. Greater blood loss, greater operative time, takes you at least a month to get over it. Can't lift anything over 10 pounds. That's an open repair. Using an endovascular, 1 to 2 hour procedure done in what we call a hybrid room. So it's a combination of cath lab in the OR, small incisions or percutaneously, stay overnight, go home the next day. Do what you want. No activity restrictions. Lower blood loss, faster recovery. It's a huge game changer. And actually, we started doing these in the chest. So we've done 2 people here in the last 6 months where we've actually treated those thoracic aneurysms. So talk about going to Seattle, getting your chest opened up, and possibly your abdomen opened up in conjunction, replacing that whole section. And oh, by the way, that open procedure has about up to a 20% chance of being paralyzed with the open procedure. So it's a big, big difference of how we do and the risk associated with that.
And you never get to be centerfold and Playgirl magazine again.
Oh, you can. So, heart gets all the marketing and all the love, but it really is all about the pipes. Thank you.